Greetings. My name is Corey Langer. I'm the Director of Thoracic Oncology at the Abramson Cancer Center, University of Pennsylvania. It's my privilege today to be joined by Karen Reckamp, who's the Division Director of Medical Oncology at Cedars-Sinai in Los Angeles, or is it Santa Monica? I'm not quite sure, but definitely on the West Coast. So we have sort of this East-West Coast coalition here today. We're going to discuss the whole issue of resistance on EGFR. Including acquired resistance in the setting of sensitizing mutations, EGFR 19 and 21 predominantly, and then also de novo resistant exon 20 mutations and how we're handling that. And Karen, a lot has happened in the last 10 to 12 years. Heck, it's only been 15 years, I think, since since the EGFR mutation was truly discovered, and the field has just advanced so rapidly. What would you say is state of the art at this point for patients with the EGFR mutations? In our neck of the woods, it's maybe 10, 15%. I realize in the West Coast, it's a higher percentage. Karen?
So yes, on the West Coast, we probably see 30 to 40% of our patients, especially with advanced disease, who have EGFR mutations. And the state of the art is osimertinib as first-line therapy for patients with actionable, most commonly L858R or deletion exon 19 mutations in EGFR. The alternatives of potentially adding ramucirumab to erlotinib, which has been approved, or the data that's been shown internationally with chemotherapy and first or second generation EGFR TKIs, I think the thought is that the toxicity is more and the efficacy hasn't been compared, so osimertinib still is the frontline choice.
Would you have equipoise joining or enrolling patients on a trial comparing OC alone to OC plus chemo, a PEM platinum regimen, particularly if they had high tumor burden?
I would. I think that patients respond very well to chemotherapy. They respond very well to osimertinib as long as they can remain on all of the therapy. I think it's worth looking into whether we can have more cell kill and prolong that progression-free and maybe even overall survival.
Certainly the trials from Japan and South Asia showed not just a PFS benefit, but an astounding OS benefit. I mean, the one from Japan was about 13 or 14-month improvement, I think from about 38 months to 51 or 52 months, and the median hasn't even been reached yet in the South Asian trial. And the one from India, of course, they didn't have built-in crossover necessarily. So some of the things that, some of the approaches we take for granted here in the West, or at least in North America, weren't occurring there. We've not really seen any survival advantage yet for the trials adding angiogenesis inhibitors to TKIs. I guess we're certainly still waiting for that in the context of Relay and some of the other trials. Outside of a clinical trial, would you consider that approach, or you think that, again, the toxicity in the absence of a survival benefit is not warranted?
At this time, I think the lack of survival data, the toxicity, the tying patients to IV therapy, when they're on oral therapy, they're able to relatively live their lives over several months without coming into the clinic. So for all of those reasons, and cost, I think for all of those reasons, on a clinical trial is the best way to evaluate those combinations rather than as standard of care at this time.
I agree, and I think outside of a clinical trial, I wouldn't usually consider this approach. Unfortunately, acquired resistance is almost inevitable in the vast majority of our patients. Median PFS in the FLORA trial was about 18, 19 months, and certainly by 3 or 4 years, the majority of these patients had experienced disease progression. So what's your approach to resistance? It's a ubiquitous issue. We're so happy that these patients are doing better, certainly better than they would have done in the dark ages before we had recognized EGFR mutation when they were treated with chemotherapy alone or chemo plus bevacizumab. But cure, at least to date, has not been realized. So what can we do to first evaluate for resistance, and then what are some of the therapeutic options in that setting?
So evaluation for resistance has changed dramatically with the use of osimertinib as frontline therapy. We know a lot about resistance when patients receive erlotinib, gefitinib, afatinib, and the emergence of T790M in more than 50% of these patients. And so that was a relatively easy, straightforward algorithm to get another biopsy or liquid biopsy, look for T790M, and proceed with osimertinib in the majority of those patients, and usually chemotherapy in those patients who didn't exhibit T790M. Now we're looking at a whole new world of resistance that really is in its infancy of investigation. And so I think that most of the data we have is really, that's published, is really on patients who have progressed more rapidly, because the approval for osimertinib in the front line was about 2 years ago. So we're only starting to see these patients who have the prolonged benefit to osimertinib and then the resistance mechanisms. But what we do know is that patients do get secondary mutations. The most common is C797S, but that's only about 10 or 15% of patients. Again, that may be because we haven't seen the longer term patients who have developed resistance. I think it may become more common as we see these later resistance patients. Certainly in my practice, I see more C797S in patients who have recently progressed after being on for 18 to 24 months. c-Met has been, or MET amplification has been of high interest and could be anywhere from 5 to 15%, but we do have active combinations for these patients. And so looking for MET amplification is incredibly important. And then small cell transformation, again, is something that we also see. And so when we don't see an active bypass pathway, if we do a liquid biopsy, which is probably the most common way to look at resistance in patients, is important to think about biopsy, and especially if there's rapid growth of a tumor, because small cell is often seen.
So out of curiosity, do you think the patterns of resistance and those who started on osimertinib up front, first line, are similar to those who received it second line in the face of T790, who then went on OC, presumably suppressed the T790 clone, and then have developed, I guess you could call it secondary acquired resistance? Or do they differ in any manner? Are we seeing similar percentages of 797S or MET amplification, HER2 for that matter? I've seen some BRAF, in fact, in some of these patients. Or do you think there's a different pattern?
So again, I think what's published, I think is going to be different than what might be published a year from now, as we get more data in these patients who have progressed later. But what you see is I think a much more heterogeneous types of resistance in patients who have received both erlotinib or first or second generation EGFR TKI with osimertinib. And so that level of heterogeneity, I think the more common thing we see in osimertinib right now are unknown. Right. There's a huge proportion that are unknown. And so I think, again, this is an area that needs to be studied. And I think we're going to find some significant differences. And similar to the ALK story, where those patients who progress on lorlatinib after they've had multiple TKIs, they have very, very heterogeneous mechanisms of resistance. But if you give it up front, it'll probably be more of a handful of mechanisms of resistance that we see.
What is your default option, assuming you've gotten both a liquid and tissue biopsy, and you don't really, it fails to disclose an obvious mechanism of resistance? It's perhaps the original mutation, or even that's been suppressed. How do you generally treat these patients?
So without a mechanism of resistance at this point in time, chemotherapy is my go-to. I will say clinical trial for all of these patients. We hope that we can put these patients on clinical trials, because we really don't know the best course of action. And whether to use chemotherapy with angiogenesis inhibition or chemotherapy with immunotherapy, hopefully we'll have some of those results soon, but we don't have that data in this patient population.
We do have some data, I guess, in the context of Empower 150. Of course, it was a very limited cohort where the quadruple drug regimen, the combination of angiogenesis inhibition and checkpoint inhibitors, immunotherapy with bevacizumab and atezo plus pac carbo is better than the old ECOG 4599 regimen, basically bev pac carbo. As I recall, and you can correct me if I'm off, Karen, I think it was just about 100 patients. It wasn't a huge cohort, but the hazard ratio there was pretty impressive. It was about 0.55. So at least some possible benefit for the addition of immunotherapy in this context, but it's the only trial I'm aware of that's even attempted to begin to isolate that role. And certainly you wouldn't use immunotherapy alone. If a patient had, say, hypothetically a high PD-L1 and it developed resistance, would you go to single agent, or would you still default to chemotherapy?
I still default to chemotherapy. I think there's enough evidence out there that single agent immunotherapy has response rates in the 5% or less, based on retrospective, and then the Lisberg article that actually tried to do this to patients and looked at scans after a month of immunotherapy for the high PD-L1. They had one responder, and that was a patient who actually didn't have an EGFR mutation. And so I think it's a pretty risky thing to do to give immunotherapy alone, and we know that chemotherapy works very well in these patients.
Going back to T797, when you've established that, I know there's some issues behind the positioning of the mutation, whether it's cis or trans. What have you typically done in these patients, either on or off study?
So for patients who have both T790M and C797S, again, clinical trials is where we go, chemotherapy. Some of these patients we've tried, and again, this is through clinical trials for the most part, we've tried the combination of osimertinib and necitumumab. And I think at this point, the data is still pretty small numbers and more anecdotal, but there are some reports of responses. And then going back to the old combination of afatinib, cetuximab, and some of the mutations may have some activity with afatinib, but obviously if T790M is there, it's a big challenge to treat, and we're looking forward to some of the next generation inhibitors.
What about grafting gefitinib onto OSI?
So that's another possibility. I think the T790M and C797S combination makes it highly unlikely that patients will respond. And I think the other key piece is that, as you know, that resistance is very heterogeneous. And so you may get a response in the lung, but progression in the liver. And we see this all the time in these types of patients with the more therapies they've received. Become very challenging to treat.
Different clones governing different components of different metastases, certainly.
Right.
Before we finish up, if you could just mention some of the new strategies for MET. I guess some of the older strategies that we have in our therapeutic bucket right now, but some of the potential newer agents that might hold promise here.
So one of the agents is the combination antibody amivantamab, that is a c-MET EGFR antibody, and that is being evaluated in patients with c-MET, has had responses regardless of type of resistance in patients who are EGFR mutants. And then the combinations of EGFR TKI with the capmatinib or tepotinib are also of high interest, and then potentially savolitinib, which is a little bit further along, has done more trials looking at the combination. So each of these have response rates. They've all been a little bit different in how they've looked at MET amplification, and so it's generally the patients with the highest MET amplification that are responsive. Yeah. And so that all of those things I think need to be worked out as we get more of this data. But it's exciting to have some potent MET inhibitors that look like toxicity-wise they can be combined with EGFR inhibitors.
And so basically grafting these agents, previously I guess we were using crizotinib, but now with the availability of capmatinib and eventually tepotinib, that would probably be preferred. Grafting these onto OSI, correct?
Correct.
Onto osimertinib, yeah.
Correct.
Well, this has been fantastic, Karen. You've really reviewed the length and breadth of acquired resistance. I think one of the points you made, you may not want to rely on liquid biopsy alone. Certainly in patients with fulminant progression or progression in sites that weren't originally involved, we've got to rule out small cell. It's a clear piece of the pie, unfortunately. Transformation anywhere from 4 to 15%, depending on which study you look at, and you're not going to discover that on a liquid biopsy. And frankly, just going to a standard non-small cell regimen may not be sufficient in that situation. When that happens, do you typically continue the original TKI with chemotherapy, or do you hold it?
Well, that's a great question. And in most of these patients, if you look at molecular testing, they will have the original mutation. They may have T790M or C797S, but they're really, the small cell does not appear to be responsive to that, to the TKI therapies. I generally will stop the TKI in part because of the toxicity, and there is added toxicity. Unless a patient has brain metastases that have been responding, I will then continue the TKI for brain penetration.
So it's a case-by-case, patient-by-patient decision.
Right.
Thank you, Karen. Been terrific. I thank you all listening in on this first part of our two-part discussion on resistance mechanisms in EGFR.
Thank you, Corey.
Thank you.